Hey class, this is your first lecture on documentation and advanced health history taking and decision making. So today we're going to talk about health history taking, the comprehensive versus the focused history, documentation, and oral presentations. You have a number of items in Blackboard as also for your review, so make sure that you go through those. The components of the health history are listed here. It starts with the identifying data, moves down to the chief complaint, present illness, the past medical history, the family history, social history, and the review of systems is the final part of the health history. So all of these areas should be listed in a comprehensive note. And the pertinent areas should be listed in a focused SOAP note. And we'll talk more about that in a bit. The identifying data includes the patient's name, age, gender, potentially their ethnicity, the source of the information. For example, if the grandmother is bringing a child in, then the source of information is the grandmother. Or if the wife is bringing a husband in who has had a stroke and can't make his needs known, then the wife would be the source of information. You also want to potentially talk about the reliability of the source, if they're a good historian or a poor historian. The source of referral, referred by Dr. Ham for geriatric assessment, or whoever brought the patient in, and that's an area that doesn't have to be always addressed. Sometimes the insurer information will be here. In an EMR or an EHR, the electronic health record, this information is usually in the top banner, so you can just import that into your note. An example of this is Joe Brown is a 34-year-old self-referred uninsured Caucasian male. So that's a brief identification. It has the patient's name, his age, his gender, that he's self-referred, his insurance, he's uninsured, and his ethnicity is Caucasian. The next part of the pyramid is the chief complaint, and this is the reason the person is seeking care today, the reason they're in the clinic today, or the reason you are involved with the patient's care today. So sometimes it's a new or episodic problem, like sore throat, cough, congestion. Sometimes it's an acute follow-up. So let's say the patient had pneumonia and you saw them last week for pneumonia, and you're seeing them today for follow-up pneumonia to make sure that it's resolved, to make sure their WBCs are improved, that they're breathing better. It can sometimes be a routine follow-up. So the patient is in today for a follow-up of diabetes, or 3-month follow-up for diabetes and hypertension. And then finally, it can be an annual exam. So sometimes the chief complaint is just here for their annual exam. The chief complaint is generally clear, concise. Sometimes you can use the patient's own words. If the patient has a whole bunch of problems, so if you ask them, why are you here today? And they say, oh, I have sore throat, runny nose, congestion, and a headache. It's helpful to sometimes ask, what's the worst symptom? And then that symptom becomes the chief complaint. And sometimes if they're very verbose, then you need to summarize what the patient's saying and then put that as your chief complaint. But it shouldn't be this long rambling sentence or even paragraph. It definitely shouldn't be a paragraph in the chief complaint. It should be a short little area. So here is an example. I say, hi Joe, what brings you in today? And Joe says, I've been sick for a week and it's getting worse. My nose is stuffy and I have a headache. So what do you think the chief complaint is? Kind of depends. You could put that whole thing if you wanted to, but you could just put, I've been sick for a week and it's getting worse, and you could put that in parentheses. Or you could ask him, what's your worst symptom? And then if it's headache, you could put headache there, or whatever the worst symptom is. So far, we have the identifying data and the chief complaint. So this is what it might look like, not really on a SOAP note because you'll be handwriting these, or it'll be in the electronic medical record or typing these. The next component is the present illness. Sometimes this is called the history of present illness. This is really where the meat of the information goes. This is, the identifying data is just, a couple of bullet points of factual information. The chief complaint is a short little blurb of why they're there. The present illness really expands upon why are you here? It's that story that explains the chief complaint. It's organized often by what we call the symptom analysis. In symptom analysis, some people call it old cart. This is your onset, location, duration, characteristics of the complaint, alleviating factors, aggravating factors, things like that. And we'll talk about that. There's a slide of that in just a minute. Inside the present illness or the history of present illness, there's a lot of information that should be included. The story behind the chief complaint, also the focused review of systems, which is also called the pertinent positives and negatives. So this is all the other symptoms or systems that could be involved that you're asking about, and you're recording that in this area. You should also include information about the patient's risk factors. You should include medications and allergies. And you may even include habits like tobacco, smoking, and illicit drugs. This part is actually social history sometimes, or past medical history, but some people, especially nurse practitioners who really focus on health assessment or who really focus on health promotion, tend to put it here. That way they can address it every single time. So for an example of this, you could ask a patient who has a cough and fever. You might ask about history of travel, so that's a risk factor, right? Risk factor for tuberculosis. You might ask about smoking history because that's a risk factor for lung cancer. You might ask if they have past medical history of cardiac or respiratory problems. Those might be risk factors for pneumonia or COPD exacerbation. So those are all information about risk factors that you can put in the history of present illness. If you identify a problem or an issue when you're taking a health history, you should make a plan to address it in your note. So for example, when you're asking these questions, if the patient says, oh yes, I do smoke 2 packs of cigarettes per day, well, that information should be recorded. You should put a note, a little note to yourself, and then put down in your assessment and plan tobacco dependence, and then your plan should be to discuss cessation and quitting helplines and things like that. So the symptom analysis is really what it sounds like. You are analyzing the symptom. So you're looking at what a symptom is, and then you are analyzing it. So you're looking at the location of it. This, you need to be specific, use anatomical and medical terms. So if someone has stuffiness, so Joe, the guy we just saw earlier that we've been talking about, has stuffiness, right? So you might ask location, where is it? Is it both of your nostrils? Is it is it worse in one side than the other? The quality, is it, if it's pain, then you're asking about burning, aching, stabbing, sharp. If it's a cough, you might be asking, is it hacking, dry, moist? If it's stuffiness, that's kind of hard to qualify, but the quality of it, is it hard to breathe? Is it, that sort of thing. The severity and the quantity, this on a pain scale could be mild, moderate, severe, or a pain scale of 1 to 10. I like to put things in terms of functionality. So if a patient's complaining of shortness of breath, I ask them, are you able to walk and do your daily activity, your living activities of daily living? Are you able to go check the mail? Are you able to walk up the flight of stairs to your room? Things like that. The timing, this includes onset, the duration, and frequency. So there's multiple different components of timing, not just when did it start, but when did it start, how long, what's the duration of the symptoms? It started on Tuesday, but it went away and came back. Does it come back every day after dinner? Do you have abdominal pain every single day after dinner for an hour after you eat dinner? So the onset is different than the duration and different than the frequency. Your onset might be 3 months ago. The duration might be, my stomach hurts for an hour until I take Tums, and then the frequency is every night after dinner. So the timing includes all those different areas. You can also talk about the setting in which this occurred. Did you have ankle pain? Well, tell me about that. When did it start? Oh, I was playing basketball and I twisted my ankle. Or I was playing basketball. I don't remember twisting my ankle, but I was really active and running around. Things like that. The modifying factors, these are what we call aggravating and alleviating factors. And don't forget also here you can talk about treatments tried and the effect of it. So aggravating, what makes it worse? Is it worse at night? Is it worse when you are eating? What makes it better? It's better when you take certain medications. Is it better when you prop yourself up at night? If we're talking about stuffiness, is it better if you sleep with 3 pillows? If it's better if you sleep in a recliner? Things like that. And then the associated signs and symptoms. This is your focused review of systems. So you are looking at the different systems and talking about the symptoms of each of those systems. Does that make sense? Did I even say that right? So for someone with a cough, you might talk about the constitutional section and say, do you have any fever or chills? You might ask the patient, obviously, respiratory questions. Do you have, how bad is your cough? Do you have any associated shortness of breath or hemoptosis? You might ask about abdominal symptoms, like do you have any abdominal pain with your cough that's associated with your cough? Do you have any chest pain? You could ask about cardiac symptoms. Do you have any chest pain, edema, swelling in your legs that are associated with your cough? Because that might lead you to think more chronic or congestive heart failure versus pneumonia versus asthma versus a cough related to gastroesophageal or reflux disease or something. So your associated signs and symptoms are your pertinent review of systems, sorry, ROS. Okay, so how do you remember those 7 attributes, those 7 symptom analysis? Well, there's a mnemonic that is helpful. It's called OLD carts. OLD stands for onset, location, and duration, and then the carts part is the characteristics, alleviating and aggravating factors, related symptoms, or in the case of pain, radiating pain, the timing, and the severity. So that can help. You might just need to memorize that, and that can help you when you're taking your health histories. Okay, so out of all of those different areas, the most important that I think is the most important is the associated signs and symptoms. They all of the symptom analysis give you clues as to what the problem is, and they tell a better story, but the associated signs and symptoms are really where you develop your differential diagnosis and you start to put in your clinical reasoning pieces. So your associated signs and symptoms are other symptoms that are related or potentially related to the chief complaint. These are called the pertinent positives and negatives, and also called a focused review of systems. So a lot of different names. So the clinician might say, hey, so do you have anything else going on? Do you have any fever, chills, any watery eyes, itchy or runny nose? Do you have any facial or dental pain? Do you have any sore throat, cough, or shortness of breath? And then Joe might say, oh yeah, I felt feverish last night, but I didn't take my temperature. And I had some facial pain and some headache too. So then your pertinent positives are going to be fever, facial pain, and headache. Your pertinent negatives are going to be chills, watery eyes, itchy, runny nose, sore throat, cough, and shortness of breath, right? So your positives are the things that he says, yes, I do have that. And your negatives are going to be the things that say, no, I don't have that. And depending on what he says yes to and what he says no to, you should be able to form your differential diagnosis or what you think the cause of his symptoms are. So the fact that he has facial pain and a headache looks like it's more potentially related to sinuses, sinusitis or sinus infection, versus if he had cough and shortness of breath and a sore throat and things like that, then it could be more URI, upper respiratory infection, or potentially even allergies. So nurse practitioners are well known for our holistic approach to patient care, and part of that is making sure that we're addressing health maintenance and health promotion at our visits. And so one way to do that is to ask about the patient's habits at every visit, every time. So ask about tobacco, ask about alcohol, and ask about illicit drugs. And then be prepared to provide recommendations and education on those. And you need to make sure that you're doing this in a way that is non-judgmental and that it's really helping the communication, opening communications up between the nurse practitioner and the patient or the client. And that's the CAGE questionnaire that you guys have probably seen in nursing school, just for you to review. If you identify a problem during that during that information, then you need to make sure that you're jotting it down on paper and developing your problem list so that when you finish your SOAP note, you can go to the end part, the A and the P. The A is the assessment, what we also call impression, and you can list them there. Acute sinusitis, alcohol abuse, and then your plan for each of those. Provide information to assess alcohol abuse and readiness to stop and things like that. Um, if you already know the patient is a smoker because it's already written in the documentation or you saw him 2 weeks ago and you don't have to ask again, but every once in a while you need to ask, hey, are you still smoking? You want to quit yet? So I can help you. And then let them say, no, I'm not ready, or something like that. And then go ahead and go on from there. Okay, so when you're recording the history of present illness, you don't have to record it in an old cart, bullet point fashion, and you don't actually even have to ask it in an old cart fashion. So you don't ask, when did your symptoms start? Where are they located? How long have they been going on? Instead, you need to let the story flow naturally from the patient. So you ask a couple questions. Hey, tell me about this. What's going on? When did this start? Oh, yeah. So how, what is the cough like? Are you coughing stuff up? And allow the patient to tell you the story. And then your job then is to take that story and make it sound medical in the medical chart. So you summarize what they said. And then you record the pertinent positives and the pertinent negatives. So Joe also complains of fever, headache, and facial pain, but denies chills, rhinitis, sore throat, cough, or shortness of breath. Does that make sense? Also, if the patient comes in for two unrelated issues like knee pain and cough, then you need two different paragraphs in the history of present illness. They don't have to be large paragraphs, but you do need to review both of those problems separately. For your follow-up HPI, so all of that was really more pertinent to someone who comes in for an episodic concern, a focused concern. If it's a follow-up, like follow-up pneumonia, follow-up diabetes, something like that, then this section is more of an interval history. So you discuss what's happened since the patient was last seen, the course of treatment, the disease progression, complications, etc. So in this case, you might have said, patient came into the clinic 3 days ago for dysuria and painful urination. At that time, urinalysis was collected and she was started empirically on ciprofloxacin, whatever, 250 twice a day for 3 days. So then you talk about the interval history. Since then, patient reports her symptoms have improved, although she's still having some burning at the end of urination. Urinalysis was collected 3 days ago. It's now back for review and shows, and then you would list what it shows. So you kind of do an interval history. What happened, a little bit of a summary of what happened 3 days ago, and then what's happened since then. Does that make sense? Okay, so the next component is the past medical history. This area might be really big in a comprehensive visit. So if you're seeing someone for the very first time, or if you're seeing someone in the hospital for a hospital history and physical and H&P. Otherwise, it can be sort of short and just list the diagnoses that the patient's had in the past. This might be a little bit hard for you to see, but there's 3 major sections of the past medical history. If you're doing a comprehensive, a big review of their past medical history, then you'll assess their childhood illnesses, their adult medical history, and then their health maintenance also goes here. So immunizations, screening tests, lifestyle issues, home safety, all of that. The past medical history for childhood illnesses, you're looking to ask about a history of measles, mumps, rubella, chickenpox, rheumatic or scarlet fever, polio, chronic childhood diseases, things like juvenile rheumatoid arthritis or things like that. Even asthma, you might want to jot that down. You'll also note really serious injuries, car accidents, big things. Not, sometimes you can get a little carried away listing every broken bone a child has had, which might be important if they've broken a lot of bones and you're concerned about potential abuse and issues. You can also record recurrent conditions, like for example, ear infections. You might list, the child has had 6 ear infections this year, and that might help support the need to get T-tubes placed. You'll also want to list any hospitalizations, the date, and the reason why. For the adult illnesses, you'll ask about chronic conditions. You'll ask about recurrent conditions, serious injuries, hospitalizations, and then this is where you can also discuss the sexual history. Some people put sexual history in the social history as well. It doesn't really matter to me where you put it as long as it's documented in a comprehensive note, or in a pertinent note, in a focus note, only if it's pertinent. So if your focus note is related to a sexually transmitted infection or birth control use, then you may want to get a sexual history. Otherwise, you just do it when it's pertinent, when it's related. You don't necessarily, for your past medical history, if the patient doesn't have any diagnoses, like they've never been diagnosed with a chronic condition, you don't need to say, past medical history negative. You can actually put no, denies history of diabetes, hypertension, hyperlipidemia, things like that, especially if it's related to something that's going on right now. If they have a cough, if you're seeing a 65-year-old female with a cough, then you can say denies history of asthma, COPD, or chronic or recurrent respiratory issues, something like that, because it's really related to what's going on as well. The sexual history, you guys will have a presentation, I think, on this. Someone will at some point in the semester, but I like to use the CDC 5Ps. And this is how many partners have you had. This is number and gender. Never make assumptions. You'll feel like a jerk if you start to make assumptions and then the patient has to correct you. You can ask about practices. Do they have vaginal intercourse, anal intercourse, oral intercourse? Protection. The next P is protection. So protection from STIs, condoms, how often are they used? If they're monogamous, then that might not be needed, but they may need counseling for pregnancy prevention, which is the last P. The past history of sexually transmitted diseases. What's been diagnosed? When? Is there any current symptoms? And then finally, the last one is pregnancy. Assess if pregnancy is desired. If it's not, then you may need to counsel on, then what are you doing about that? Do you need to be on birth control? So the sexual history really should be obtained anytime there's a pertinent reason. So if the patient comes in for birth control, the patient comes in for an annual pelvic exam, the patient comes in for vaginal discharge. And it also should be done at annual exams and potentially even on new admission paperwork and comprehensive visits. The rest of the past medical history, the surgical history, dates and procedures, OB/GYN history, this is for females obviously, GTPAL is the gravida, total pregnancies, preterm, abortions, and living. So I think you guys talk about this in your women's health lectures, in your women's health course, but it's good to know and to record that information. You can talk about the menstrual history, when their menses started, so the onset, their cycle duration and length, and then their contraception, and you can also put sexual history here if you like. And then finally the psychiatric history. For health maintenance, you're looking at the patient's immunization record to make sure that their immunizations are up to date and that you are asking about any age-appropriate vaccinations that they may not, that aren't mandatory but that are recommended. So make sure that you're looking at the CDC immunization schedule for those. I've put that in Blackboard for you as well, but that's a really that's some important information for you to know. You don't necessarily have to memorize this information, but you may for the quiz or the test, but you can print these out and keep them. You should have a general idea of what immunizations are age specific, but the exact schedule for those you may have to reference as you work with this population. And then any screening tests like pap smears, TB tests, colonoscopies, mammography, cholesterol. When was it last done and what were the results? And if it hasn't been done, then you need to then recommend that it gets done. So there are intervals that you want to do these that you should be aware of. So pap smears, we used to recommend pap smears be done every single year, but now we're saying, oh no, they can be done every other year or every third year, depending on previous results. So a really good place to look for this information and to find the information on the screening ages and duration between screening is the USPSTF, the United States Preventative Service Task Force. So you can go to USPSTF and look something up and see when they should have it done. And there's actually a list also, and I think I may have put that in your Blackboard, but you can take a look. If it's not there, then you look at USPSTF. Again, here, if you identify a problem in their health maintenance, then you put it in your impression. You can put it in your impression. So here I just listed health maintenance, but you can say, needs flu vaccination or vaccinations, and then your plan is to give flu shot information, patient declines but will return next week. The next component of the health history is family history. I don't do a lot of this because I work in geriatrics, so a lot of my patients are in their 90s. And at that point, family history may or may not be really relevant, because if they, the family history of hypertension that my 90-year-old patient tells me about isn't really going to change my treatment for her because she's, 90. And if she had hypertension, then if she didn't have hypertension, then she's probably not likely to get it at that age, at that point. So you'll ask about family history of hypertension, CAD, which is coronary artery disease, hyperlipidemia, stroke, diabetes, thyroid conditions, all these different areas. And then also the cancers are really important: breast cancer, colon cancer, ovarian, prostate, lung. And then you document denies family history of hypertension, coronary artery disease. You can list them. You can actually list that what they've denied a family history to, instead of just saying negative family history. If it's positive, then you can list who that history is positive in. So grandparents, parents, siblings, and children. We don't generally go beyond this list. So you don't need to go beyond that kind of first-degree relatives. You can do a genogram. These have sort of fallen out of favor. No one really does them anymore, but it's an option for you. The genogram shows, if it's darked out, then the patient has died. If they've died, then you put Y: car accident, infancy, unknown cause. You put their current name, or you put their current age, and then usually an arrow describes who the person or who the client is. So this is our patient Joe. We know Joe's a male, he's a square, so Joe has a brother, and Joe is married to a 36-year-old, and then Joe has a little sister who died in infancy. So he's got one living brother, he's got a wife. Him and his wife have 4 kids. He started when he was 20, so he has 4 kids. And then his mom and his dad. Dad has passed away. His mom is alive. His mom is 62. So his dad might have died. His dad died at the age of 54, but if he was still alive today, he'd probably be older, in his 60s. Okay? Okay. The social history is the next part. Social history, you can list things like occupation, marital status, education level, religion, hobbies, living situation, like who lives in the house. Any safety measures, it's an important area to list this. So use of seat belts, helmets, sunblock. Here in Hawaii, if you're dealing with little kids, then a lot of water safety issues, and even adults too. For elderly, include things like baseline function and ADLs. And then for children, do they go to daycare? What's their living situation? Any smoke exposure, etc. The last thing is the review of systems. We've talked somewhat about this when we talked about just the pertinent review of systems. So if you see someone for an episodic concern, you're going to do just the areas that are pertinent to the reason the patient's being seen. Other times, you might do a full-on systematic review of every system, and usually this is done at comprehensive visits. So it's a series of head-to-toe questions. It might remind the patient of problems or issues that they might have otherwise forgot about. You can and should start broad and then go more specific. So, for example, do you have any problems with your lungs? And they might look at you like, no. And then you can say, have you ever had any chronic cough, shortness of breath, ever been diagnosed with COPD or asthma? And then they might say, oh yeah, I have asthma and I use an inhaler every day. And you're like, but you just told me you didn't have any problems with your lungs. So you start broad and then you ask more specific questions. You'll do that for each of these systems. So there are a number of systems. We usually talk about review of systems for the 10-point review of systems is negative. That means you talked about 10 of these different points and that you asked the questions and they're negative. But these are the CMS approved systems. So constitutional, things like fever, chills, eyes, do you have double vision, trouble seeing, blurry vision, ears, nose, and throat. This is all one system. So you can talk about trouble hearing, hearing loss, congestion, sore throat, things like that. Integumentary is the skin and breast. Do you have any skin changes, rashes, skin lesions, changing skin lesions, any breast pain, breast changes? Do you have any respiratory issues like cough, shortness of breath, hemopturia? Cardiovascular, you might ask about chest pain, chest pressure, palpitations, shortness of breath can go there as well. Peripheral vascular, and the list goes on. And there's a list of review of systems questions in Blackboard for you, but you can ask any of those questions. And you should ask all of them. Now, sometimes people don't have time to sit there and ask the patient all of these questions. So when you go and see your provider for your annual exam, they might just hand you a template and you just check. You just check no problems, no problems, no problems, no problems. Or you can circle the areas that you do have a problem. And then the clinician will review that form. Okay, so if we're talking about a focused health history, those are concerns that are episodic in nature. So someone who comes in for one particular reason, a cough or shortness of breath or knee pain or toe pain or blurry vision or neck pain or whatever that is, that's a focused health history. You don't need to talk about every single thing we just talked about. You can just focus only in on the most important information. So in that case, you'll always include the identifying data, you'll always include the chief complaint, and then you'll only include pertinent areas of the present illness, the past medical history, family history, and social history, and the review of systems. So you still need identifying data, you still need chief complaint, you still need an HPI, and then only the relevant parts of everything else. Okay, does that make sense? So let me change this. Okay, so what is the pertinent information then? So this is where I'm able to see the students' clinical decision making. I'm able to see why they, why did they include that? Why did they ask about a history of reflux disease in this patient who's coughing? Oh, in my mind, I'm thinking, oh, good. They thought about the potential that GERD is a potential issue for or potential cause of coughing. So by asking, do you have a history of GERD or any abdominal pain? And by documenting, patient denies history of GERD, patient denies abdominal pain, then I know they've thought, that they've been thinking and connecting those dots or trying to connect those dots. So the focused health history, bringing in the pertinent information really helps us see that clinical decision making, it takes time, it takes practice, and you have to know diagnoses and what is associated with those. And that, again, it takes time and skill. When you're documenting this, you can start with your SOAP notes. So I put it here out with FSPAR, which is your nursing notes, situation, background, assessment, and recommendations. And now we're talking about SOAP notes. So subjective information. What does the patient tell you? The subjective information is everything we just talked about today. Every bullet point there. So in a comprehensive health history, I'll go back in here. In a comprehensive health history, everything we talked about today, you need to document and talk about in your documentation. So a comprehensive visit is a long visit because you need to talk about every single point we talked about here. Does that make sense? So you might do these with a new patient. You might do this annually with your annual visits, H&P, and other areas. And then we have the focus, which is shorter, right? So when you document these, you start with your subjective, that's everything we talked about today. Then you can move down into your objective or your examination. This also includes diagnostics and labs and X-ray results and things like that. You might talk about those results up in the subjective history, but when you are cutting and pasting into your note, you can cut and paste the actual test into your objective information if you're going to do that. Your assessment, this is your impression. This is what you think is going on. Usually this is listed by diagnoses. So it has to have an ICD-9 code or an ICD-10, sorry. So we're not talking about NANDA, at risk for type diagnoses. We're actually talking about billable diagnoses. So pneumonia, right lower lobe, upper respiratory infection, things like that, acute cystitis. These are diagnoses that are associated with an ICD-10. And then your plan for each one of those assessment or impression areas. So you can consider prescription medications, you can consider over-the-counter, whatever your treatments are, diagnostics, if you need to get an X-ray, something like that, then put that here. If you need to give education, you can put that here, your consults, and then any follow-up. So think about those 5 areas when you're writing your note. The rules to documentation, if you didn't document it, you didn't do it. So you need to make sure you're documenting. Your documentation also relates directly to your billing, which in some cases will relate directly to your paycheck. So the more you bill, the more you get paid in certain payment models and in certain places where you're an employee. Other times your salary, it doesn't really matter. But there are many ways to document. Primary care providers generally document using the SOAP notes, but there's others like discharge summaries that look a little bit different. There's op notes and progress notes and things like that. An H&P, a history and physical, is just a really comprehensive SOAP note. So hopefully you got that out of here. Organization is key because other people are going to be reading these notes, and also you're going to be reading them to remind yourself what you did the last time you saw this patient. So make sure that your documentation is organized and neat. When you're presenting this information, when you're doing an oral presentation to a clinical preceptor or to when you're signing out for your team, if someone else is taking over care of a patient, the oral presentation is different than what you write in your SOAP note. So you write all the facts, right? But you speak only the really important and essential information. So you don't need to include all of the information. It's really the Cliff Note version of the SOAP note. So your SOAP note is the book, and the oral presentation is the Cliff Notes. So it's very brief. 1 minute usually is sufficient for acute episodic concerns. It's usually delivered from memory. You can glance down at your notes or your paper, but you shouldn't be reading it. You don't want to spend time reading it, and you certainly don't want to read your SOAP note because that's got too much information. And it's still organized in that subjective, objective assessment and plan. Okay, that's it. So make sure you guys are reviewing all the information in Blackboard and